Hello friends, I am Dr. Harbans Lal. As you all know, I am contesting for the post of Vice President AIUS. During the course of conversation with my friends and supporters, I realized many of them are advising and guiding their family and friends due to overstressed healthcare system. My team, comprising of Dr. Ikeda Lal and Dr. Tinku Bali Razdan, will discuss with the experts to bring to you Beat the COVID series of short videos to clear all your doubts and to give you authentic, precise, and brief knowledge.
Hello everyone. I'm Dr. Tinku Bali Razdan and I welcome you all to our series on Beat the COVID. Today we have with us Dr. Atul Gogia, who's a senior consultant in the Department of Medicine at Sir Gangaram Hospital, New Delhi. Dr. Gogia has been at the forefront of managing COVID-19 and has a vast experience in managing COVID-19 and its complications. So welcome, Dr. Gogia. It's a pleasure to have you here with us this afternoon. And we are very happy that you're here to answer all our queries related mainly to the investigations in COVID-19. So in the beginning, I'd like to ask you that what are the basic investigations that need to be ordered right in the beginning in a patient of mild COVID who is on home isolation?
To have a baseline investigation in the sense that we need to know a complete blood count, a liver kidney function if we do not have it at hand. So we should be knowing whether the liver function is normal, kidney function is normal. So a complete blood count, a kidney function test, a liver function test is the basic for all patients so that in case they would require any medication. So we need to know that. Apart from that, there is a discussion about the inflammatory markers. So which includes like ESR, CRP, ferritin, LDH, and D-dimer, which we should get in these patients so as to know how active the disease is.
These tests need to be done in all patients or only the ones who have a low saturation?
As I would suggest, we need to have a basic blood test, complete blood count, ESR, a CRP, a liver function test, and a kidney function test at least for every patient at the baseline. So we know that and a blood sugar. Because a lot of the medications would be affected by the liver function, kidney functions, and if we are going to go in for steroids, so we need to know the sugar status. So these are the basic investigation everybody should undergo at the baseline. And if it is a very mild disease, at least these tests would suffice. But if patient is running fever or patient has a continuous symptoms, so maybe after 3 to 5 days of the baseline, you can go for these tests so as to know how active the disease or inflammation is going on.
And thereafter, how often do these tests need to be repeated?
So, well, we have to use a clinical mind for it, but generally what we do, because it is difficult times and we are not able to, so generally every 3 to 5 days is the test timeline we keep depending on the severity of the illness. So it is a very mild disease, not much symptoms, maybe after 5 days you can repeat these tests. But somebody who has persistent symptoms or is not doing very well, in those patients, maybe after 3 days, after 72 hours, you can repeat these set of tests.
So also, what do these tests actually indicate? Like, what does CRP indicate? What does D-dimer show? What does ferritin? So if you could just give
we have to see all these tests in the clinical context. So there is a lot of confusion in the mind of the treating doctors as well as the patients alike that the test is out of range and they are worried. So tests like an ESR or a CRP or a ferritin, LDH, they are all signs of an ongoing inflammation. So normally any fever for that matter or any inflammation in the body, leave aside COVID, may cause an increase in these markers. So in the current COVID times, because mostly everybody is seeing COVID only, so these tests, if they are above the normal range, we do not have to panic. So it depends on the clinical. So if patient is running high fever or patient saturation is dropping, or patient has other symptoms which are there, and these markers are at least 3-4 times above the normal range. So that is the time we need to be much more alert. So if for example, if a CRP normal range for a lab is 6 and it comes out to be 10, 12, 15, you need to be alert. You need to see in the clinical context. So you do not have to just chase the report. Yeah, if somebody has a CRP of 50, 60, I would say yes, you need to be much more alert as to something is ongoing. So similarly with ferritin, and ferritin again, we have to be use it with a pinch of salt, because some of the ladies, as such, or undernourished people, they may have low ferritins in their body. So, anemic patients, their ferritin level may be very low, so they may not be able to mount that much of response to you to know. So you have to, that is why you need all these tests in collaboration. Coming to D-dimer. D-dimer is basically a test which would suggest there is a risk of thrombosis. So it is not specific for it, but at current time, because we are getting to know that COVID is supposed to cause increased thrombosis and vascular events. So if your D-dimer is 3 times, above the normal, so that is a time you need to be wary, and you have to see it in collaboration with how many risk factors that the patient has. The patient is an elderly patient, he or she has a malignancy, or has other risk factors making him or her prone to increased risk of DVT. So those are the patient needs to be chosen. Coming to IL-6, which is one of the most fragile tests, I would say, to be done. So in home isolation, doing IL-6 is a very, very tricky situation. IL-6 test has to be processed within an hour and a half. If my lab people would, so the sample has to reach the lab within an hour and a half. So if it is reaching late, the reports may be erroneous. So there are a lot of patients who will show you a report of 500 and 1000 of IL-6, otherwise normal being 5, 7, 8. And there is panic in the doctor as well as the patient. So IL-6 doing in home isolation sometimes I feel is a little tricky, because the sample will not reach the lab in 1 to 2 hours. So it's not possible because they're collecting. So that we have to see all these things when we are managing patients.
What about cardiac markers like troponin? Do they need also to be advised in all patients? Or?
So they are not to be done routinely in all patients. Definitely, if some patient is complaining of breathlessness, has chest discomfort, has a cardiac history, or is at high risk for cardiac disease, in those set of patients, they may be done. But I don't think so in home setting, they would be useful. If somebody has this much of symptoms, they would actually be landing up in the hospital.
So what about CT scan? What is the right time to ask a patient to get a CT scan done? And also something like CT scores, like how do you use the CT score to guide you in your treatment?
So that again becomes very tricky situation. CT scan, everybody, there is so much of panic. Everybody is running for a CT scan and they feel the CT score is 2 and 5, though they're safe. It is very mild disease. And once the CT score is 13, they have to be admitted, or 15, they have to be admitted. So ideally speaking, CT scan is a good modality to differentiate between mild, moderate, severe. But it has to be, you should not be doing a CT scan upfront. So for initial 5 to 6, 7 days, a CT scan may not pick up. It is a sensitive test, but early on in a mild case, it may not show you anything. Very early. If you do it very early, you may become complacent. You do it on the very first or second day and you get a CT score of 0 or 1 or 2, and you may feel it is fine, I'm good, I have no symptoms. So the timing should be latter half of the first week or early second week, and that too in those set of patients who have high risk patients, who are having some chest symptoms, who are still running fever, in those set of patients where you want to triage and get to know whether they are having, because X-ray is not a very good modality to pick up in early stages. So CT is much more sensitive that way. So X-ray will only pick up when you have severe disease. So, or you have to, in a follow-up thing, you may do an X-ray, but CT would be sensitive. So latter half of, first week, early second week, when the patient does have any respiratory symptoms or chest symptoms, along with is still symptomatic, and the markers are high, and there you want to triage, and patient is at high risk whether he has moderate or severe disease. So in those set of patient, probably CT would be useful. And just by CT only, the patient, you have to see, obviously all investigations have to be correlated clinically. So we have seen patient with CT score of 13, which would consider mild moderate disease, being on oxygen in the ICUs also. So you have to correlate it clinically. It is just not that CT score is low and the patient will be fine. So a clinical correlation always has to be there. But obviously, if somebody has a very high CT score, 18 and above, they feel the radiology society feels if it is 18 and above, there are high chances of having complications. So it has to be seen in the clinical context.
Right. So that was a very good point that you drove home, that the clinical context is extremely important and every patient should be under the guidance of a physician. Patients should not treat themselves or shouldn't get these tests done on their own and then start interpreting them on their own.
Yes.
So thank you, Dr. Gogia. That was a very informative session. You cleared all our doubts about the basic investigations that need to be done in the case of COVID-19. Thank you so much for being here and answering all our questions so patiently.
Thank you for having me. Thank you.